So I'm going to talk today about what it's like to try and use data science to harness an advanced EHR and improve analytical maturity in a regional health authority. So just to give you a bit of context, so I'm the Director of Clinical Analytics and Clinical Information Services for Vancouver Island Health Authority, which is a regional health authority in BC. And basically we're responsible for all of the residents on Vancouver Island. And so that accounts for about 850,000 people. Most of them are down here in the bottom right-hand corner. And then as you go north, as everywhere else in Canada, it becomes fewer and fewer. For those residents, we provide a large range of services. So we provide community health services for patients that are individuals that are still living within their home, primary care, ambulatory care services, acute services, including emergency department and inpatient visits, as well as long-term care services. And across all those different service streams, we are in the process of rolling out an advanced EHR that connects all of those services at the patient level so that there is one patient record for all of the services we provide. I think this is running by itself. Okay. So what is clinical analytics? So clinical analytics is a lot of things. We do a lot of stuff. I'm going to highlight the ones that I think are most of interest to this group. But these are kind of all the buckets of work that we're responsible for. Most notably are things like data management, data and information management, setting up new tools and technologies to do sophisticated analyses, conducting analysis, and communicating the findings that we have to different kinds of stakeholders within the health authority. At the center of all of this is our kind of vision or the thing that we're meant to be doing across those different service streams, and that is increasing analytical maturity at Island Health. A lot of what that means is, like, right now, or before we started, a lot of the data and information and analytics that was conducted within the health authority could be distilled down to counts and rates. Most of what was happening was how much of this is going on. And that's kind of where analytics was at. So part of our goal is to increase the maturity as the scope and granularity and dimensionality of our data increases with the rollout of the EHR, is to push analytics further so that we can provide better, more complex pieces of information to support decision-making and providing care to patients. So data and information. I see that there's chat coming up. I can't really keep track of chat. So can someone let me know if I need to answer a question?
Brandon, our plan is to have questions at the end, and someone is tracking questions.
Perfect, thank you. Okay, so I'm going to talk about data and information management. I'll tell you a little bit of a backdrop to this. So when I first applied to this job, I applied to the job based on the job description, which looked really cool, which was almost like research level analysis in the health authority. I've been in this job for 4 years, and the first 3 years we did very little analysis because almost all we did was data development and data quality. There's a lot of data and information management required to do this kind of work. And when you're working with these advanced EHRs, it's important to understand that they are built as operational systems to help with the delivery of care. The data they collect isn't structured in a way that is primarily there to support secondary use or analytics. So a lot of work has to go in on our end to go into the back end and create data sets and find meaning in the data to do the analyses we need to do. So just to give you a picture, when I talked about the range of services that are provided by Island Health and that we're rolling out this advanced EHR, which gives us our data to do analysis, this is happening in a very fragmented and iterative way. So the way the EHR is rolling out, as you can see, like this is our roadmap over the next 3 to 5 years for what's being turned on or activated in terms of electronic functionality, which will therefore give us new data so we can do more comprehensive analysis. It's split by different kinds of streams. So community health is turning on different pieces in different locations across the years. Primary care is turning on different pieces of functionality across different locations across the years. So what that means is that we have to keep track of what's being turned on. But in terms of being able to leverage that new functionality, we have to also be careful to know that we can't do it everywhere, because if the primary care functionality is available in West Shore, we can't integrate it with community health until community health turns on its electronic functionality for West Shore. And those things aren't perfectly aligned because the decisions about the rollouts are based on far more considerations than just what we could do for analysis. This is what the actual data set behind Cerner looks like. So I talked about the fact that it's an operational system. Everything that gets entered into Cerner, which is our EHR, it's stored as data somewhere in the back end, and that back end is called Cerner Millennium. Cerner Millennium is a set of more than 1,000 tables, each of which has dozens to hundreds of columns. There's a lot of data back there that's very distributed. And part of what we have to do is go into that data and figure out how do we get what we want out of it, because it isn't always intuitive. And a good reason for that is that you would like to think when you buy a very expensive EHR that has all this functionality, that it has been developed kind of like it's evolved and it's kind of linear. So once you figure out how to find order level information for lab tests, that you should be able to generalize what you found and use similar tables to find order level information for medical imaging or pharmacy or patient care orders. But that's not the way it is. Cerner was initially a lab information system. And what's happened is that over the years, it started buying other functionality by absorbing other companies that had new functionality. And every time a new piece was bought, a team was brought in to integrate it with what already existed. But every time a new piece was bought, so once lab started, once you added medical imaging, a team sort of integrated the medical imaging functionality with the lab functionality. Then they bought pharmacy. Well, then a different team came in and integrated pharmacy with what was built in terms of the integrated lab and imaging functionality. So you've got different people taking different approaches every time that a new functionality is added. So it didn't evolve in this nice linear way. It looks more like Metalbeard. It is just a nightmare to unpack. So we spent months figuring out how to map all of the steps in the workflow from the point in time that a physician orders a lab test to when a sample is drawn from the patient, it gets transported to the lab, it gets put into the machine, where are the results stored? We figured all that out. Then when we moved to pharmacy, none of our learnings from lab mapped. Similar kinds of information was stored in different places. So a big piece of work. And if you're thinking about working in a health authority with these advanced EHRs, a big piece of that kind of work or the kind of tasks that you would be doing are data development, assessing data quality, working with information stewards for the different systems to improve data quality through data improvement, and storing lots and lots and lots of metadata. I don't know why I can't escape out of my thing. Give me one sec. I want to show you what we've done. So the way we've approached this is we've built what's called an Information Governance Council. So this is an Island Health intranet page. So I put the link in to help me, but if you're not an Island Health employee, you're not going to be able to follow the link that's in the slides that I sent. But basically, as we're building new data sets, as EHR functionality rolls out, part of our job is to engage with subject matter experts and information stewards to fill out a data quality template that maps all of the pieces of their data, does comprehensive data quality assessment across the different dimensions of data quality, shows them where they need to improve, and write out data quality alerts for which dimensions of their data are not fit for purpose for conducting analysis in the health authority. Okay, big piece of work. Another sort of service that we provide, another task or skill set that we look for when we do data science within the health authority is really tied to the tools, technology, and infrastructure. So what that means for us is that all of our analytics occur within what's called our enterprise data warehouse. So we have many different systems, right? So I talked about Cerner. On the left-hand side, you'll see all the different data systems that we have running within Island Health. We bring Cerner data into the EDW. We bring in ORSOS data, which is surgical data, into the EDW. Paris data, which is our community health services and long-term care data. We're bringing Procura data, White data, many different data sources. We bring all of that into our enterprise data warehouse, which is a Microsoft SQL server. Then our ability to leverage that data in the EDW, what tools we can use, are kind of yoked to the fact that it's Microsoft SQL Server. So Microsoft SQL Server 2019 has machine learning services. So that means that we use either R or Python as our sole tools for conducting analysis, and that we leverage Microsoft Power BI for our dashboard reporting and integrated reporting tools. So those are the kind of tools that we use. I think it's important for you to understand that it's really difficult to say you should learn R or you should learn Python, because that's what works for us in our health authority. But then when we work with the ministry or other health authorities, their data warehouse solutions and their tools may be different. So I just think it's good to know, like, for example, I spent 8 years at CAI as a methodologist. CAI exclusively used SAS. I came to the health authority, they don't use SAS. SAS costs money, it's expensive, the health authority is poor. And so all my expertise in SAS just got thrown out the door, and I had to relearn R so that I could conduct analysis at the health authority. I think it's important to know that the tools you learn will be useful in some health authorities, but not others. And if you move, or if the server structure changes, you may have to relearn the tools. So it's really important that when we look for staff, what we really look for is, do you know how to conduct analysis? But we're not so worried about if you know how to use R versus SAS or whatever, because the way we think about it is, if you know how to do the work, like how to think through conducting an analysis, we can teach you R. And we actually have like a series of modules that we work through. And we also kind of leverage the training that's available at the university as well, to bring you up to speed on a specific tool. But for us, the skill set that's more important is the methodology and the statistical knowledge rather than the tools per se. Another thing I just want to talk to you about is that the kinds of analyses we do are very complex. So when we did an analysis, what we did is, it was just a basic set of analyses, not basic, but we went through and we needed to understand, for all of our patients that came to our hospitals with sepsis, what were the kinds of interventions that were being done to initially recognize and manage sepsis at the front end. How good were we at doing blood cultures? Were we getting them as soon as possible? How good were we at giving them the right antibiotic as soon as possible? We did that analysis to help inform the health authority on whether or not there were opportunities for quality improvement. That analysis, when you write it out in R, is 5,221 lines of code. So if you print that out, and when I give this presentation, I do presentations on reproducibility, I bring a printout of this, because when you print it out on 10-point font on 8.5 by 11 sheets of paper, that's a 79 foot long piece of paper. What that means is that because the consequences of the analytical work that's done in the health authority could lead to, physicians being investigated, allocation of scarce resources that say we're going to focus on sepsis rather than falls. We have to be hyper careful that when we do our analysis that we do it right. So another sort of thing that we talk about is reducing reproducibility errors. So we have a basic process that's called shadowing, where a primary analyst will write up the methodology, access the data, and run an analysis to produce their result. When they do that, they write out what's basically like a methods section of a paper, pass that to a second analyst who can only use that methods section and tries to replicate using the same data, the same result. If the results don't match, they have to go back and forth by revisions to that technical document only until they match perfectly. So that's the process we take to try and reduce as much as possible or eliminate errors, because the coding is so complex. So that's sort of the tools, technology, and infrastructure. The other service or sort of function or skill set that we will obviously need are analytics. So just going to talk about one of them. I'm not going to go into detail. Basically, we do all kinds of analysis, right? So all kinds of regression, cluster analysis, machine learning, prediction, et cetera. Like we do lots of that kind of analysis. This is one of those stories. So basically what we were asked to do was to validate this pre-existing score. It's called Homer. And what it does is how am I for time? Okay. I'm good. Okay. What it does is it takes a bunch of information that's available about a patient when they first come into the hospital, and it predicts the likelihood that that patient will die within the next year. The reason we were doing this is that we were asked by our palliative care service to help them identify if there are patients coming into the hospital that are not known to palliative care. So we wanted to set up this algorithm that would run, and as a patient was admitted, the score would be calculated, and if they met a certain threshold, it would trigger an alert to palliative care so that they could come and do a consult with the patient. The reason is that there were PSLS events which were indicating that patients were palliative but not known to palliative care, and we needed to improve that in our health authority. In order to do that, we had to harness many different pieces of data from many different data sets, right? So we had to look at information about ambulatory services that were related to the ambulance. We looked at their ED data. We looked at the inpatient admitting information. We had to pull from what's called the ministry's chronic disease registry, which is part of the common ground data that we have, to calculate their Charlson index, gender, age, living situation, and whether or not they were admitted directly to the ICU. First thing we do is we have to validate, does that score work for us? And, we ran the analysis and it worked. So kind of doing that kind of analysis, by pulling multiple different data sources together in the enterprise data warehouse is the core sort of analytical work that we do. But another thing that we do, because we're kind of like yoked to that rollout of the advanced EHR, is that what we did with this is after this was done and sort of once we got our machine learning services up and running in the EDW, which was fairly recently, we did a little neat piece of work where we ran some machine learning to do some dimensionality reduction. And we asked basically, okay, you have all this data that we are going to go back to care providers and say, you each have to enter all of this data at the time the patient is admitted so we can calculate this score to improve the connection with palliative care. We did that because that was a pre-existing score that was in the literature and was leveraged by other hospitals across Canada. Once we got our machine learning services up and running, we did dimensionality reduction. And what was kind of interesting is that we found that even though the Homer score is based on all these different pieces of data, basically all you need is your comorbidity index and age, and there's an interaction between those two. That's it. There was no significant difference between having just these two pieces of information and all of these pieces of information. So we're actually able to reduce down the data requirements at admission to put less burden on the people entering data and still maintain the same level of predictive accuracy. Why that matters is that as we've been rolling out our advanced EHR, there's this issue of adoption. So you turn on a new functionality and our ability to leverage the data that gets stored as a result of that functionality requires not just that we turn it on, but that people actually use it before we can get the outcome we want. And this isn't unique to us, but what we've been finding is that adoption is not always as comprehensive as you would like. So part of what we did is we created, this is a Power BI report. So if we go into our report portal, you kind of go in and it creates this sort of like web type interface that gives you access to information that's in our EDW. So now what we do is every time that we try to harness data from the EHR, we kind of have this report that's up and running and is available to everyone in the health authority that says, okay, we've turned on electronic documentation in community health. One of those documents is the assessment for short-term clients. What's the percentage of new short-term clients that had that document filled? 63%. We have a target of 80%. And then this says that basically the trend is the same. So basically what we do is we create this, it's like a performance report for the adoption of the EHR so that we're trying to push the organization to adopt it. Because if people aren't adopting, like if we look down here, like only 54% of patients are getting their allergies documented. If we want to do an analysis where we need to control for allergies, or we need to check if the patient was allergic to the medication and therefore it should have been a PSLS event, we can't do that analysis if we're missing half the data. So this is kind of like integrated with the work that we do. And that just kind of brings me to the last piece that I'm going to talk about, which is communication, which is really about how do we disseminate the outputs of our analytics. And that really is an important thing. And I almost feel like I should put communication in education. Because of our drive to focus on analytical maturity, what we're learning is that oftentimes when we're trying to communicate what we find with our analyses, we also have to spend quite a bit of time educating stakeholders to understand the information we're providing them. When you're used to seeing counts and rates, and we start talking about like three-way interactions and associations and risk factors and all that kind of stuff, people just glaze over. So we actually have to spend a lot of time educating people as well as communicating with them. And one way we've been doing that, or one big piece of work we're doing in that area, is leveraging all that data we have in the data warehouse to build an interactive report for each physician so that each physician that has inpatient privileges in our health authority can log into this report. They log in using their Island Health account. The data warehouse reads that account and allows them to view a customized report that gives them information about the patients that they've treated in the hospital, the outcomes those patients have experienced, the quality of care that was received by those patients while they were in the hospital, etc. We're kind of in the process right now of rolling that out. So this outer circle reflects the departments or divisions that we have created a profile for us. But you can see like surgery and medicine, like there are some services that we haven't provided. But another skill set or competency that we need when we look for people to do data science is the ability to do this kind of visualization and communication with clients. So this is our physician profile report. It's kind of neat. It's empowered by BI again also. And you can kind of go through and you can kind of click, if you want to click and say, oh, I want to look at what it looks like for females. You just click on the female part of the bar and it'll kind of reduce it to the females only, or you can click it again and it brings you back to your full cohort, gives you information about what the individual providers look like versus their service or department overall. And you can look at safety measures. So one of our big safety measures is hospital harm. So this says for each physician, if they log in, it says, what's the hospital harm rate for your patients compared to your service overall? And then what's kind of neat too is that because we have record level data and physicians have the right to access records for patients they've been the most responsible provider for, if they want to do quality improvement, they can just click on this link and it drills down and gives them the record level information about every patient that has experienced hospital harm that they've been responsible for. So it says, oh, here's this record when they were admitted, when they were discharged, what kind of harm they got VTE, et cetera, et cetera. So there's information that goes across here. This is a display or like a demo version of the profile. If we have a more detailed version that each physician can access, but I can't show it to you because that contains personal information. But when a physician were to log in and their version of this profile, it would give them the chart number as well. So if there's data that we don't have electronically that we can display to them, they can go and they know which chart to look for, which if you've ever had to be involved in doing chart reviews, you know, will say it saves them a lot of time. Okay, so that's what we do in clinical analytics. Any questions?